السلام عليكم. أنا الدكتورة إيمان شفيق شافعي، مدرس واستشاري طب الأطفال بمستشفى بالريش الجامعي. النهاردة هنتكلم على الفاسكولايتس. تعريف الفاسكولايتس: الفاسكولايتس are disorder defined by the presence of inflammation in the blood vessel wall. Inflammation ممكن يكون primary أو secondary underlying disease. Clinical symptoms vary widely depending upon the type of the vessel affected or the location of the vessel involved, extent of the inflammation, and the subsequent vessel wall damage with associated hemodynamic change. Classification of vasculitis: it may be primary vasculitis or secondary vasculitis. Primary vasculitis. Primary vasculitis is classified according to the vessel size, either predominantly large vessel vasculitis or predominantly medium-sized vessels or predominantly small vessels or other vasculitis. Predominantly large vessel vasculitis, the first example is Takayasu arthritis. Predominantly medium-sized vessels is polyarthritis nodosa and Kawasaki disease. Predominantly small vessel vasculitis is henoch-Schönlein purpura, which is called also IgA vasculitis, granulomatosis with polyangiitis, which is called also Wigner granulomatosis, hypocomplementemic urticarial vasculitis, Serge stress syndrome, hypersensitivity, isolated cutaneous leukocytoplastic microscopic polyangiitis. Other vasculitides are Behçet disease, Cogan syndrome, isolated vasculitis of the central nervous system. Kawasaki disease. Diagnostic criteria of the Kawasaki disease is that fever for more than 5 days plus 4 of the following: bilateral bulbar conjunctival injection, mucous membrane changes, injected pharynx, cracked lips, strawberry tongue, extremity changes as edema, erythema, desquamation of the hand or feet, polymorphous rash, and cervical lymphadenopathy at least more than 1.5 centimeter. ده شكل البايلاترال conjunctival injection. الصورة دي بتورينا الcracked lips and strawberry tongue. الصورة دي بتورينا الإديمة of the hands. والصورة دي بتورينا desquamation اللي بيحصل في الهاندز and feet. ده شكل الراش اللي بيحصل على الترانك في حالة الكوازاكي. الصورة دي برضو بتورينا شكل من أشكال الديسكوميشن اللي بتحصل في الكوازاكي. Other manifestation of Kawasaki disease are arthritis and arthralgia, which present in 7 to 25% of the patient, involve large and small joint. Urethritis causes trypyuria, CNS involvement as in the form of septic meningitis, facial nerve palsy, and hearing loss. GIT symptoms in the form of abdominal pain, diarrhea, vomiting, and hepatitis. Cardiac involvement in the form of coronary artery aneurysm and myocardial dysfunction. عشان كده الإيكو مهم جدا جدا في حالة الكوازاكي. Kawasaki disease differential diagnosis: viral infection as measles, echovirus, adenovirus, and Epstein-Barr virus, toxin-mediated illness, scarlet fever, toxic shock, rickettsial or spirochete infections, Rocky Mountain spotted fever, leptospirosis, drug reaction as Stephen Johnson, and serum sickness, GIA as systemic onset type, and mercury hypersensitivity reaction. Kawasaki disease, the laboratory evaluation markers of the systemic inflammation as elevated CRP and ESR, leukocytosis with shift to the left, reactive thrombocytosis up to 1 million. دي حاجة significant جدا في حالة الكوازاكي. بنلاقي thrombocytosis, الأنيميا, normocytic and normochromic, sterile pyuria, urethral origin, do not do a catheter, transaminase elevation, mild to moderate CSF finding, mononuclear polyocytosis, decreased glucose, elevated protein, synovial fluid inflammation, hyponatremia, increasing risk of coronary aneurysm. Kawasaki disease treatment, mainstay of the treatment is IVIG 2 gram per kg over 8 to 12 hours. IVIG may need to be repeated in refractory cases. Several studies have shown that IVIG plus aspirin decrease the risk of coronary aneurysm compared to aspirin alone, may also decrease the risk of depressed myocardial function, and the high dose of aspirin during acute illness than low dose of over about 2 months. This picture shows how the Kawasaki disease may cause coronary artery aneurysm and myocardial dysfunction. Henoch-Schönlein purpura, this is an example of a small vessel vasculitis, most common systemic vasculitis in children, immune mediated. بيحصل deposition of immunoglobulin A immune complexes, often a self-limited disease, occur more often in fall and winter and spring, rare in the summer. About 50% of the cases are preceded by upper respiratory tract infection. Streptococcus is often implicated. Vaccines, insect bites, viruses have also been reported as triggers. Henoch-Schönlein purpura classic tetrade بيحصل فيها palpable purpura in 100% of the cases in absence of thrombocytopenia or coagulopathy. فبنلاقي purpura بس ما بيبقاش معاه thrombocytopenia عشان ما نتلخبطش بينها وبين الاي تي بي، او بيبقى فيها معاهاش coagulopathy، فبنلاقي البي تي والبي سي كويس جدا والاي ان ار كويسين جدا، مش بيبقوا affected في حالة الهينوخ-شونلاين purpura. فده نفرقه عن الهينوخ-شونلاين purpura عن الاي تي بي. والارثرايتس or arthralgia in 75%, in abdominal pain in 50%, and renal disease in 21 to 50% of the cases. ده شكل البيربورا اللي بتحصل في حالة الهينوخ-شونلاين purpura، وبتبقى mainly most common يعني in the lower limb وفي الtrunk و less affect the face and the upper limb. الصورة دي بتبين شوية ان في arthritis في الرايت ankle joint، فبتبقى swollen شوية وباين ان الرجل اليمين edematous and shows arthritis. Henoch-Schönlein purpura can cause edema and submucosal hemorrhage of the GIT tract. May see purpuric lesions on endoscopy. ممكن يبقى presenting symptom of Henoch-Schönlein purpura only. Symptoms typically develop within 8 days of the rash. Intussusception is the most common GIT complication. Henoch-Schönlein purpura renal disease occur in up to 50% of the patient, ranges from hematuria to end-stage renal disease in less than 1% of the patients. Usually present within 4 weeks of the onset of the Henoch-Schönlein purpura. The overall prognosis is very good, but there is some long-term risk of progressive renal impairment. Henoch-Schönlein purpura laboratory findings. There is no definitive diagnostic test. مفيش تست يقول لنا يؤكد لنا إنه ده Henoch-Schönlein purpura. The IgA levels may be elevated in 50 to 70% of the patients. Platelet count and coagulation studies should be normal. وده بيخلينا نفرق من الباربورا بتاعت الاي تي بي ولو في coagulopathy. Inflammatory markers may be elevated, which is as ESR and CRP may be elevated. Urine analysis, red cells, white cells, and CAS and proteinuria may not be present until later in the course of the disease. Remember to continue urine analysis screening after the acute phase. لازم نتابع urine analysis screening لمدة 6 شهور بعد ما يخف، علشان ممكن يحصل acute renal failure وتقلب end stage renal disease، بس قلنا دي نادرة في less than 1% of the patients. Negative rheumatoid factor and ANA test. The treatment of the Henoch-Schönlein purpura, it is conservative treatment. Steroid in the following conditions only. Severe intractable abdominal pain، ده معناه ان يبقى فيه gastritis، او occult blood in stool برضو معناه ان في gastritis، او لو في nephritis renal affection يبقى steroids only في حالة gastritis and nephritis only. ما بنديش steroids في الراش، لو في راش بس او fever بس نديله بس non steroidal، او أو لو في arthritis أو arthralgia هنديله non steroidal، بس الستيرويدز only في حالة الجاسترايتس and nephritis. دلوقتي هنتكلم على الحاجات اللي بأفكت الميديوم سايز muscular arteries as البوليارترايتس نودوزا. الكلينيكال picture of the polyarthritis nodosa: fibrinoid necrosis within the wall of the affected blood vessel, arteries not veins, microaneurysms. An angiographic hallmark of the polyarthritis nodosa. ده اللي بيأكد لنا ان ده polyarthritis nodosa عن طريق ان احنا نعمل CT angiography ونلاقي microaneurysms. Constitutional symptoms: fever, fatigue, malaise, myalgia and arthralgia. The kidney, the most commonly involved organ. Renin-mediated hypertension and renal insufficiency may result. Cutaneous manifestation: livedo reticularis, nodules, ulceration, frank ischemia of the digits. Cutaneous polyarthritis nodosa is a variant limited to the skin. Polyarthritis nodosa can also cause neuropathy in 50 to 75% of the patient, usually as an asymmetric sensory and motor neuropathy due to ischemia of the peripheral nerves. Infarction of the nerves results in mononeuritis multiplex. GIT symptoms in 50% of the patient: postprandial, peri-umbilical pain or intestinal angina, nausea, vomiting, diarrhea and GIT, bleeding, testicular pain or tenderness in 33% of the patient, coronary involvement detected only at autopsy. This picture shows childhood polyarthritis nodosa, which shows gangrene of the forearm and the lower leg in 3 months old infant. Polyarthritis nodosa في laboratory finding بنلاقي الانتي نيوتروفيل cytoplasmic antibody negative، ودي حاجة بتفرق لنا عن الفاسكولايتس اللي هي ANCA positive vasculitis هناخدها later on. Being a seronegative disease, there is a difficulty in a diagnosis. مفيش حاجة conclusive بالlaboratory investigation تقول لنا ان دي polyarthritis nodosa. طيب ازاي نقدر نشخص البوليارثرايتس نودوزا؟ الدايجنوزس ممكن يكون بالفيزيكال examination cutaneous features as livedo, nodules, ulcers, digital ischemia, signs of vasculitic neuropathy زي muscle wasting, foot or wrist drop, and CT angiography هيورينا guided by symptoms abnormal arteriogram, characteristic stricture or aneurysms, biopsy من السكين من المسل من peripheral nerve biopsy to aid the diagnosis. Differential diagnosis criteria have been developed to help distinguish polyarthritis nodosa from other vasculitis and rheumatic disorders. الصورة الأولانية موريانا CT angiography وبيورينا arteriogram فيها multiple aneurysm on arteriogram، والصورة التانية فيها autopsy specimen بتورينا شكل polyarthritis nodosa. American College of the Rheumatology classification of polyarthritis nodosa: at least 3 of 10 criteria should be present. Weight loss more than or equal 4 kg, livedo reticularis, testicular pain or tenderness, myalgia, weakness or leg tenderness, mononeuropathy or polyneuropathy, diastolic blood pressure more than 90 mm mercury, elevated serum nitrogenuria أكتر من 40 mg per deciliter or creatinine more than 1.5 mg per deciliter, hepatitis B virus infection, arteriographic abnormality, biopsy of the small or medium-sized artery containing polymorphonuclear neutrophils. Polyarthritis nodosa treatment: glucocorticoid. About half of the cases will be cured with glucocorticoid alone. Cyclophosphamide in case of rapidly progressive or life or organ-threatening polyarthritis nodosa. Takayasu arthritis is a large vessel vasculitis, primarily affects the aorta and its major branches. Takayasu arthritis diagnosis. The ELAR criteria require mandatory finding of angiographic abnormalities of the aorta or its main branches and pulmonary arteries, and at least one of the following 5 features: pulse deficit, لإما lost or decreased or unequal peripheral artery pulses, and or claudication induced by activity, systolic blood pressure difference more than 10 mm mercury between any limb, bruit or thrill over the aorta or its main branches, hypertension, elevated acute phase reactant. Angiographic confirmation may be performed by conventional radiography, CT or MRI. Takayasu arthritis treatment include mainly glucocorticoid, which is highly effective in suppressing clinical manifestation, aspirin to reduce the risk of ischemic events, and methotrexate. Data on its potential for steroid sparing are mixed. This is the aneurysm and the dilatation of the aortic arch, typical finding of a Takayasu arthritis. Granulomatosis with polyangiitis, which is also called Wigner granulomatosis, systemic vasculitis with granulomatous inflammation, affects small and medium-sized arteries. Granulomatosis with polyangiitis, which is called also Wigner granulomatosis. Classification. The ELAR classification criteria require 3 of the following 6 features: renal involvement in the form of hematuria, proteinuria, or red blood cell cast, or necrotizing pussy, immune glomerulonephritis, upper airway involvement in the form of chronic or recurrent purulent or bloody nasal discharge or crusting or recurrent epistaxis, laryngeotracheobronchial stenosis, pulmonary involvement in the form of chest X-ray or CT show nodules, cavities or fixed infiltrate, ANCA positivity, PR, C ANCA or C ANCA staining, granulomatous inflammation within the wall of the artery or in the perivascular or extravascular area on biopsy. The diagnosis of granulomatosis with polyangiitis is by histopathology, gold standard for diagnosis in most cases. Exclude rheumatoid arthritis, the combination of joint complaint, cutaneous nodules, and the high frequency of the rheumatoid factor positivity among patients with ANCA-associated vasculitis often lead to misdiagnosis of rheumatoid arthritis early in the disease course. Granulomatosis with polyangiitis treatment include mainly glucocorticoid, which is the cornerstone of the therapy, rituximab, the preferred agent for remission induction in patients with severe Wigner granulomatosis, cyclophosphamide, now the second-line agent for the treatment of severe disease because of the toxicity concern, azathioprine or methotrexate for remission maintenance therapy. Methotrexate may be used to induce remission in case of limited Wigner granulomatosis. دي صور بتاعة الهاند and the lower limbs and heel show purpuric papule and hemorrhagic vesicles and bully of the age of 16 years. والhistopathology بتاعها بيبين ان blood vessel فيها fibrinoid necrosis with occluded lumina, dense perivascular neutrophilic infiltrates with leukocytoclasia. And the picture D shows saddle nose deformity at the age of 21 years. نوع تاني من أنواع الفاسكولايتس بيبقى بسبب hypocomplementemic urticarial vasculitis syndrome, low complement level and urticaria for at least 6 months, as well as some or all of the following: arthritis, glomerulonephritis, scleritis, uveitis, angioedema, chronic obstructive pulmonary disease, pleurisy, and pericarditis. Other forms of vasculitis are as Church-Strauss syndrome, considered to be a eosinophilic variant of Wigner granulomatosis. Asthma is the most common sign. It is generally considered an adult disease and it is rare in children. Microscopic angiitis, usually presented by focal segmental glomerulonephritis, often result in pulmonary hemorrhage. Hypersensitivity vasculitis occur as a part of hypersensitivity reaction to a known or suspected antigen. Other vasculitis are due to Behçet disease, very rare systemic vasculitis of unknown etiology, affect blood vessels of all sizes, both arteries and veins. Clinical manifestations are similar in children and adults, characterized by recurrent painful ulcers of the mouth and skin and uveitis. أهم حاجة بتميزهم ال painful ulcers في الماوث وفي السكين وتبقى recurrent and uveitis. Clinical presentation of the Behçet disease are as abscess stomatitis, genital ulceration, which is very specific in Behçet disease, uveitis, GIT symptoms due to ulcers, and arthritis. Laboratory finding normally in rheumatoid factor, ESR and CRP may be elevated. ده شكل ال recurrent ulcers اللي بتحصل في ال Behçet disease في الماوس. Cogan syndrome, sensory neural hearing loss, bilateral, often recurrent, progressive and profound, ocular non-syphilitic interstitial keratitis, scleritis or uveitis are the most common eye manifestation. Systemic بيحصل headache وفيفر وarthralgia وvasculitis with or without aortitis. Secondary vasculitis are due to underlying disease زي ما هنقول في السلايد التاني. Secondary vasculitis is due to underlying etiology as infection, vasculitis secondary to connective tissue disease as systemic lupus erythematosus, drug hypersensitivity, vasculitis secondary to mixed essential cryoglobulinemia, malignancy أو post organ transplant أو pseudo vasculitic syndrome زي myxoma or endocarditis. Thank you for listening.